Welcome back, friends. Now, in the last session of the day, we will be deliberating upon management of hyponatremia. We have requested again Dr. D.S. Rana, the chairperson of Department of Nephrology from Gangaram Institute, to kindly present his views with regard to management of hyponatremia. Sir.
Thank you. Good evening, listener. If you are still listening to me at this fag end of the evening, that on a very interesting, fascinating topic of hyponatremia. Hyponatremia is a important clinical topic, and it is very important to know when to treat it and when not to treat it, because both decisions are very important. It's just something like damn do it, damn do not it. Treating it also unnecessary can be fatal to patient, and not treating it can also be equally fatal. My slides on these topics are very interactive, but since the interaction during this program is not possible, I leave these slides those for your own self-assessment. You can do your own assessment. Before I jump to how to treat hyponatremia and when not to treat, it is very important to have basic knowledge of certain hard facts of hyponatremia. This slide is for your self-assessing note. How many of you know that what is the molecular weight of sodium? And that's 23. What is the molecular weight of chloride? You go on assessing yourself, the 35.5. So what is 1 gram molecular weight of sodium chloride? 58.5. Because this is all this knowledge should be known to you to drive the factor that how much 1 gram of common salt, how much sodium delivered to the patient. And in my experience, many times when I ask this question to the DNB students, even after spending few months in the course, they don't know such simple facts. So now next slide is that in 1 gram sodium chloride, what is the amount of sodium and chloride delivered? It should be equal amount, but so simple equation that you have to divide 1000 milligram, because 1 gram contains 1000 milligram, and divide it by 58.5, that is the molecular weight of sodium chloride. Your answer is 17.09 milliequivalent, or for all practical purpose 17 milliequivalent. So next question comes that let us say you prescribe 1 teaspoonful of salt to a patient. How much sodium delivered? And 1 teaspoonful, small teaspoonful of salt, not heaped one, but it's level one, that contains 5 gram of salt, and then eventually 5 gram of salt should have say 85 milliequivalent of sodium and 85 milliequivalent of chloride, and that's what you should know actually. And then that is your common knowledge again, that what is the sodium in 1 liter of normal saline. This also many students they are not able to answer sometime, and this should be also on your fingertips that this is 154 milliequivalent, and there also not just that somebody told us 154, there is a formula to drive it. Again you divided it by the same thing, and it was 0.09%, that means 0.9 gram divided multiplied by 1000 milligram, that becomes grams, then multiplied by 10, that becomes into milligrams, divided by 58.5, this comes to 53.84, and for practical purpose taken in 154. And sodium in 1 liter of hypertonic saline, that is 3%. Again 3 multiplied by 1000 multiplied by 10 to convert it to milligram, divided by 58.5, it becomes 512 or 513 milliequivalent. So you should know that the sodium in molecular weight is 23, chloride 30.5, and 58.5 is the molecular weight of sodium chloride, and 1 gram of sodium chloride, common salt, contains 17 milliequivalent of sodium, and 1 liter of sodium, or say normal saline, which we call 0.9%, contains 150 milliequivalent of sodium, and sodium in 1 liter of hypertonic saline is equal to 513 milliequivalent. This figure should be on a tips while correcting hyponatremia. So we go to next slide. And so what is your concept of hyponatremia? And you answer yourself. Hypoglycemia, deficiency of glucose, replaced with glucose. Simple. Hypovolemia, the depletion of extracellular fluid volume, replaced with fluids. Hyponatremia, deficiency of sodium, replace it with sodium. Very simple answer. Is this answer correct or not? This is the concept of hyponatremia and this is its treatment. So think in your mind, and the answer is big no. So it is not like something like that. It is a glucose deficiency, or the hyponatremia is not necessarily deficiency of sodium. That may or may not be there. But so what is the definition of sodium hyponatremia? The concept of hyponatremia is that hyponatremia is a disorder of water balance rather than that of sodium balance, and its concentration is governed by osmolality and osmotic forces. Hyponatremia reflects too much water in relation to sodium in a particular solution, so that it is not a normal sodium which is 135 to 145, and potassium at a given time. So that should be, the concept should be very clear, that hyponatremia is not a disorder of sodium. Hyponatremia is a disorder of water balance, and that has to be very clear. Only then you will know that how to manage it, and then you will see what is the concept of management, And it is not simple that somebody is having hyponatremia, then give saline or give sodium or give hypertonic saline, So what is the plasma osmolality? That is the next thing you must know, Because it is basically the water concentration in the body is being determined by plasma osmolality or various different. And the plasma osmolality is determined by the concentration of number rather than size of major plasma solutes in millimoles per liter of plasma. So how do you calculate plasma osmolality? And answer is 2 multiply sodium concentration multiplied by 2 because 1 for anion, so chloride will be equal amount of bicarbonate or something, plus glucose divided by 18. This is molecular weight of glucose 180, so 10 has gone. Similarly, blood urea nitrogen divided by 2.8, the molecular weight of B1 is 28, because once you convert it into and these are important. Normal plasma osmolality is between 275 to 290 millimoles per kg. Though sodium salts are main determination of plasma osmolality, regulation of plasma osmolality and the plasma sodium concentration is mediated by change in water intake and water excretion. And these things are, glucose and blood urea nitrogen, they become important contributor towards osmolality in the presence of diabetic ketoacidosis and renal failure. What happens when plasma osmolality increases? Whenever we say that plasma osmolality is increasing, that means the concentration of water is going down. In a given solution, if the solute concentration goes up, the water concentration is going to go down, And so, and water will move from higher concentration to lower concentration. You will just see. But if let us say because of some reason plasma osmolality goes up, immediately one gets stimulus for increased thirst, and next thing is increased ADH due to stimulation of osmoreceptor in the hypothalamus. That leads to increased water intake and decreased excretion of water, and water is added to the body. There is a water retention and osmolality restored back. So that means basically it was, once we say osmolality is going up, that means there is a deficiency of water there, in that particular situation. The cycle will be reversed in the decreased plasma osmolality, that you will know. What determines water movement between two compartments? That is very important to know. Is the concentration of water. Water, like any other cation and anion, will move from one compartment to other compartment along osmotic gradient. That is from higher concentration to lower concentration. And I made you amply clear that if the osmolality is higher, then water concentration low. If osmolality low, then water concentration high. So from low osmolality, it will always move to higher osmolality. In which compartment water concentration is higher? Hyperosmolar or hypoosmolar? So some of you must be thinking, and answer is obviously hypoosmolar fluid. Okay. So we go next. What is the daily solute overload? We take food that is converted into urea, creatinine, phosphorus, so many things, and we take salt, we take sodium chloride, we are taking potassium. All those things are added to our circulation, and excess has to be thrown out. Whatsoever is required by the body to maintain the milieu interior, that is osmolality, and for maintaining the various enzymatic function of the body. Apart from that, everything has to be thrown by the kidney out, and that solute overload is, you must be knowing, 600 milliosmoles for a normal person about 60 to 70 kg. This is the 600 milliosmole per kg. These many osmoles you have to get rid of the body. Whether they will be consisting of sodium, they will be consisting of urea, they will be consisting of creatinine, uric acid, whatsoever is excreted in the urine, or drugs. So they will be out, So in order to get rid of this 600 milliosmoles, next question is that what is the range of urinary osmolality with normal kidneys? And this is 50 to 1200. You know that the tonicity of the inner medulla is 1200 milliosmoles. That is very hypertonic, and that is responsible for making the urine formation. I will not go in that cycle, but normal kidneys are able to dilute urine to as little as having only 50 milliosmoles per kg to as high as 1200 milliosmoles per kg. So if normal kidney can work in this range, then what is the capacity of normal kidney to form urine? So let us say if somebody passing maximum diluted urine, he is taking a lot of water or because of one reason or other, he has to get rid of 600 milliosmoles. If let us say 50 milliosmoles is the osmolality in the urine, then he is getting rid of 50 almost osmoles in 1000 ml. In order to get rid of 600, he will require to pass almost 1200 ml, 12,000 ml of urine, that is 12 liters. So one can pass urine, a normal human being with normal kidneys at a young age can pass as much urine as 12 liters. While if he doesn't take any water at all, even then person can pass still 0.5 liter of urine, and the urea, creatinine and sodium, potassium concentration will not be altered in the blood. That's the beauty of normal kidney, and that is what you should know. Now next few slides are what is the pathogenesis of hyponatremia. And in order to understand, it is very important to understand that in the body we have got two compartments, intracellular compartment and extracellular compartment, and the water is distributed in all compartments. It is only that they differ in terms of concentration of salts like sodium, potassium and calcium, phosphorus. While calcium, phosphorus and potassium are the main intracellular anions cation, sodium chloride and calcium, magnesium and chloride bicarbonate protein, they stay in the extracellular compartment. In fact, extracellular compartment, as you know, all of you, that is divided further: interstitial compartment and intravascular compartment. Intravascular compartment and interstitial compartment, as all of you know, the very basic thing that they are separated by nothing but endothelial lining, And this endothelial lining is quite permeable to sodium, potassium, magnesium, water. But this membrane, very thick membrane, which is separating intracellular compartment from extracellular compartment, is sort of a permeable membrane which is freely permeable to water along the concentration gradient, but is not freely permeable to sodium, potassium and other things. So the only water which can move from this compartment to this side, this to this side very freely. The rest of these, they require a very active transporter, and that is what you have to maintain. So, and in the body it is very important that the size of this cell is maintained to maintain the integrity of this compartment. If this cell, then there is the cellular edema. If this shrink, then there is cellular shrinkage, And that is why it is very important to understand this thing, And out of total body water distribution, 60% water is in intracellular compartment and 40% is in extracellular compartment. Out of that, only 10% is in intravascular compartment and 30% in interstitial compartment. So I hope that I have made it very clear that you remember this membrane. That this membrane is have a very vital importance to maintain the integrity of the cell, to maintain the interior of the body. So what happened that if you add salt, that is what I want to prove in next two slides, that adding sodium and deleting sodium from the diet or to the body will not alter osmolality at all. Sodium can only increase extracellular fluid volume or decrease, because sodium cannot enter the cells, so it has nothing to do with the cellular size. So you add sodium to the body, you give sodium to the person, use normal saline or no common salt. What will happen? He will take equivalent amount of water, and there will be increased thirst, and there will be volume expansion, and plasma osmolality will also go up temporarily. Once plasma osmolality is going up, as I told you, then temporarily osmolality is going up, then water is moving out from the compartment in order to equilibrate, because there cannot be differential osmolality between two compartments. That is very important. So what happened that once moment the extracellular fluid volume is expanded, there will be hormonal response. There will be suppression of renin, angiotensin system, and aldosterone. And this will lead to increased excretion of sodium and water. Because there will be no aldosterone there, aldosterone suppression will be there. As a result, there should be sodium and water excretion in the urine. The result will be that there will be restoration of this plasma volume, and the water will again make inward movement. The cellular volume will be also restored, and this will be restored very quickly. So there will be no chance of alteration of cellular function. So you have seen that adding sodium doesn't contribute to osmolality. Adding sodium doesn't change the sodium concentration also. Adding sodium will not lead to hypernatremia or hyponatremia. It will lead to only volume expansion. So sodium determines the volume expansion of extracellular fluid compartment rather than osmolality. That is very important to understand. So let us see the other slide. Let us say we deplete the salt. We don't give somebody salt, or on the other hand, there is depletion of salt because of vomiting or diarrhea and all this. What will happen? Whether you will get change in the osmolality immediately? Not, because there will be volume contraction. Now there will be stimulation of RAS system, and there will be more aldosterone. So this will lead to decreased excretion of sodium water, and there will be water retention and sodium retention. As a result, there will be volume expansion here, and the plasma osmolality will go up, and the water movements will also reverse, So addition and deletion of sodium salts to the body compartments does not bring any change in the osmolality. So proving thereby that hyponatremia has due to nothing with the sodium. Now what happens if you add water in extracellular fluid volume? You add water here, immediately water moves to equal amount of water moves to intracellular compartment also in order to equalize the osmolality, and sodium concentration goes temporarily here. The down regulation of osmotic receptor in the hypothalamus. As a result, there is suppression of ADH, and there is increased free water clearance. Once you are suppressing ADH, person is going to pass more dilute urine. So you are getting rid of water, and this will happen to an extent that, and then kidney will be able to restore osmolality. So far they are normal, they have got capacity to do that. Now what happen on effect of retention of water in a normal clinical situation? But there are situations where kidneys are not able to get rid of water, excess water, either by virtue of intake. That intake is so much that person, kidneys are, this is above the capacity of normal kidney to get rid of it. Like say I told you that maximum they can take out 12 liters per day. If that somebody taking 15 liters, he cannot take off this water. Kidneys are not able to take off that water. But most of time it is appropriate or inappropriate excess of ADH, which leads to decreased free water clearance, and that adds water to this compartment. As a result, there is a dilution, there is an addition of water, and osmolality goes down. Osmolality, once you are adding water to this compartment, the water will go on inside also. The sodium concentration will go down, and so is plasma osmolality. And that is how the hyponatremia develops. And this is the situation that you have to understand. This is appropriate or inappropriate excess of ADH, which invariably will lead to decreased free water clearance, and which result in hyponatremia. And that's what you have to. That is once you know that that is how hyponatremia develops, then you will make the management very simple. What is the definition of hyponatremia? Basically, development of hypoosmolar state which leads to hyponatremia, and hyponatremia is a quick measure of hypoosmolar state. Normal serum sodium level, as you know, that is 135 to 145. Serum sodium level technically below 135 is called hyponatremia. However, patients are not symptomatic at this level of hyponatremia. In majority of patients, hyponatremia always due to appropriate or inappropriate secretion, as I have already told you, and concurrent abnormality of sodium balance may or may not be there, as you will see in the next slide. In normal person, euvolemic is sodium is 140. Person may get vomiting, diarrhea. There may be isotonic dehydration, and not necessarily patient may be dehydrated, but he may not be having hyponatremia. He is volume depleted, but not necessarily hyponatremic. Unless you give only free water, and that person may become something like that. That somebody gets hypovolemic. Now you are not bringing to euvolemic, but you have added water. Now person has become hyponatremic, or somebody may be only almost clinically euvolemic. That as it will happen in SA ADH. That water is only 3% excess, which clinically you cannot appreciate, but that is giving to hyponatremia. Or somebody may be hypervolemic, like you will find edematous states like cirrhosis, congestive cardiac failure, and you will see that there is hyponatremia. That I want to stress that it is excessive water in relation to sodium, which is important. Like in this situation, there may not be total sodium may not be deficient. In this situation also total sodium may not be deficient. In this situation, total sodium is deficit actually. Total water is also deficit. So, but still, and this is only that not necessarily that this is the only state which is associated with slightly sodium deficiency. Otherwise, there is no sodium deficiency. What are this? How do the people get symptom of hyponatremia? Hyponatremia leads to hypoosmolar state in extracellular compartment. Water moves from intracellular compartment into cellular compartment. As a result, there is a cell edema. This cell edema may not be of much importance in other cells, but this is very important in brain cells, because there is tight compartment of skull, and inside the skull is the brain cells swell. They will lead to brain edema, and patient will get, and it is brain edema which leads to symptom of hyponatremia. And as such hyponatremia. And what happened that, so that is what I told, this is how cerebral edema takes place. And hyponatremia can be acute or it can be chronic, though it is very difficult to say in a given situation, but generally hyponatremia which develops over 2 or more days, if you are knowing, it should be considered chronic. It is difficult to question difficult to answer the question in this clinical practice, since majority of patients difficult to know the duration of hyponatremia. What could be the symptom of acute hyponatremia? Patient may be asymptomatic when sodium is 130 to 135 millicurie, nausea, weakness, or early finding when sodium level fall below 130 millicurie per liter. This is followed by headaches, lethargy, and obtundation of the thinking, seizures, coma, respiratory rest may follow if sodium concentration falls below 115 to 120 millicurie. Which factor determine the severity of acute hyponatremia? It is rate of development. Number 2, degree of hyponatremia. So that is very important. Rate of development is very important, and then of course degree of hyponatremia also is important. And what are the neurological symptoms? Neurological symptoms are less with chronic hyponatremia because of cerebral adaptation to hyponatremia. You will see. That is why you should know that how did it happen. Once in the initial stage there is cerebral edema because of hyponatremia, then because of hydrostatic pressure, the water start moving out of the cells into the CSF. So that is the first step. At the same time, there is loss of solutes out of brain cells. Initially it is potassium and sodium, and later on organic solutes called osmolytes. These solutes start coming out of the cells because water cannot. So as a result, what happened that the osmolality of the cells is restored, and there is no edema. And so there is no edema, there are no symptoms. And this the same thing I have explained through diagram, that but how did it happen. But now let me go. So what can be the danger of rapid correction of chronic hyponatremia? That is very important to understand. Let us say somebody's sodium was 110, and you immediately brought it into 130. In the brain, what will happen? That sodium and potassium will immediately, they can move very nicely. Water will also go inside, or water will come here. But the most important thing that some osmoles, which I call osmolytes, those idiopathic osmolytes, this which are moved out of cells into the interstitial compartment and intravascular compartment, they do not move immediately inside the cells. It takes days together once they start moving inside, and as a result, what will happen? Now you are reversing the situation. Initially, patient was symptomatic because patient has got brain edema, brain cell edema, cellular edema because of hyponatremia. Now, what you're calling reverse, the the water start moving out of it, and there is shrinkage of the cells. So the patient now is going to symptomatic because of shrinkage of cell, and shrinkage can be to that extent that it can produce demyelination syndrome. All of you heard that CPM, and the CPM was that central ponton myelosis, and that term is quite okay. The majority of patients do get that syndrome, but it is this demyelination not confined to pontine only; it can go to the whole brain actually. That is better to call it demyelination syndrome, and that's very important. That if there is a edema on one side, then patient can die of herniation of brain. There can be severe edema, and patient may herniate, and death may ensue very quickly. On the other hand, if you correct injudiciously, rapidly, then that is the syndrome you are going to produce. So you treat it, then you are in problem. You don't treat it, you are in problem. So you have to learn when to take decision, how to treat hyponatremia, whether to treat it or whether leave it, or what are the methods of treating. So that is very important to know that symptoms of hyponatremia, they were because of brain edema, and symptoms of correcting of hyponatremia because they are demyelination syndrome. And many people will die. Actually, in fact, many people have died because of correction of chronic hyponatremia rapidly rather than leaving them like that. So that's the very important, that acute hyponatremia should be corrected, symptomatic hyponatremia corrected, but chronic hyponatremia should not be touched, and that should be gently handled. And so these are the disorders in which ADH levels are increased. That I think most of you must be knowing that whenever there will be volume depletion, obviously in order to body has got compensating mechanism to increase the extracellular fluid volume depletion, and there will be increased say ADH levels, so that water can be retained at the level of kidney, and the volume can be restored. And there is syndrome of inappropriate secretion of ADH. That also that where there is a lot of secretion, inappropriate secretion of ADH, and that leads to water retention and hyponatremia. And then there are disorders in which ADH level may be not raised, but they may be suppressed actually. But hyponatremia has occurred because of other reasons. Advanced renal failure or primary polydipsia or beer drinker protonemia. They are because osmoles are reduced in the diet. Similarly, hormonal changes. You have got three such states. Like one, renal insufficiency. There obviously you are going to have loss of sodium and retention of potassium, and hypothyroidism, and pregnancy. In pregnancy also you can have this sort of dilution hyponatremia because of hormonal disturbances. So these are the important this thing. Then hyponatremia with normal raised osmolality. That is, somebody can have hyponatremia with normal elevated plasma osmolality. So that in true sense is not a hyponatremia, because for us the most important is plasma osmolality rather than sodium concentration. So sodium concentration is being maintained by something else like hyperglycemia, mannitol. But these patients having on the other hand, unlike hyponatremia, they are having hyperosmolality. So here you can't, if you give saline to these people, then you just kill them. Normal plasma osmolality like pseudo-hyponatremia, hyperlipidemia and hyperproteinemia, and glycine solutions as used in TURP or other things. Approach to case of hyponatremia. Now I am coming to the real talk after having told you about something about basic. And whenever you get a report of hyponatremia, you should repeat the laboratory reading immediately to confirm it. Take proper history, physical examination whether the patient is really case for hyponatremia or not, and do all laboratory tests including plasma osmolality, urine osmolality, spot urinary sodium concentration, plasma, burn, creatinine, sodium, potassium, total protein, albumin, calcium, phosphorus, uric acid, glucose, lipid. They will be all important, as you must have by this time grasped from my previous slides. And then you should know fraction of excretion of sodium, acid waste balance, and other investigation to know possible underlying cause of hyponatremia. How do you diagnose SIDH? This is diagnosis of exclusion. Low plasma osmolality, obviously, inappropriate elevated urine osmolality above 100 milliosmoles. Because in most of the hyponatremic patients, there should be hypoosmolar urine, but in SIDH is always above 300 milliosmoles per kg, and it may be up to 600 also. Urinary sodium concentration usually above 40 milligram per liter in a spot of urinary sodium. Low BUN sodium uric acid concentration, a relatively normal plasma creatinine concentration, normal acid base and potassium balance, normal adrenal and thyroid function. What is the treatment of asymptomatic hyponatremia?